Hi, I'm Melissa Bottoni, and I'll be talking about eating difficulties in children with ASD. Eating difficulties are more common in children with autism compared to their typically developing peers. And some of the difficulties experienced by children with autism include rigidity around mealtime behavior, for example, using a certain cup or using certain plates or eating certain brands of food. They may experience a limited diet or texture aversions. And there are physiological and behavioral bases to these eating difficulties. Physiological bases include hypo or hyper responsiveness to certain flavors, gastrointestinal issues. They may experience food allergies, oral motor skill deficits, such as difficulties chewing or manipulating food in the mouth with the tongue. Behavioral bases of eating difficulties for children with autism may derive from insistence on sameness, difficulty tolerating change, for example, to new foods or food presented in a different way. Behavioral bases may also include disruptive behavior and refusal of food. There are many challenges associated with eating difficulties for children with ASD. The first are health implications, such as nutrient deficiencies, which may result in poor growth and may require intrusive medical intervention, such as a feeding tube. Participation in the community is also impacted negatively, such that they may disrupt family dinners or meals, as well as the involvement of the child in birthday parties, and with extended families and friends, which may further alienate a child with ASD from their peers. Children with eating difficulties are also likely to engage in challenging behavior to escape or avoid eating non-preferred foods, for example. Eating difficulties are very stressful for parents. So due to these significant impacts on the child and family, intervention on eating difficulties is important not only in treatment, but in all areas of the child's life, including school and home. Further, it's important to advocate for needed services to support development in eating. This may include advocating for teacher training or for in-home coaching for the parents to support development with these eating difficulties. Intervention is often required to improve pervasive eating difficulties in children with autism. Rarely do these behaviors extinguish without intervention. Prior to intervention, it is best practice for an exam to be conducted by a medical professional for the eating difficulties. The medical professional may provide necessary treatment or rule out physiological issues. Based on the results of the examination, the behavior analyst should assess the safety of proceeding with assessment and intervention for the eating difficulty. For example, the risk of choking should be considered. If it is safe to proceed, a variety of assessment methods can be used to determine the individual's baseline level of functioning with respect to eating. Such methods may include a food diary, which is filled out by the parents, a behavioral interview with caregivers, and a direct observation of the individual consuming preferred and non-preferred food. A functional analysis may also be required to determine the function of disruptive behavior, as it is often maintained by escape with respect to eating difficulties. And based on the results of the assessments, an evidence-based, individualized, and function-based intervention should be developed. Reinforcement is nearly always included in a treatment package targeting eating difficulties for children with ASD and is arguably the most important component. It may involve positive reinforcement or negative reinforcement following targeted behavioral responses. Related to reinforcement, escape extinction is the most common intervention used for treating eating difficulties for individuals with autism. It includes a variety of procedures, such as non-removal of the spoon and preventing escape from the eating area. For example, a child may be put in a high chair, requiring an adult to remove him from the chair, or preventing the child from leaving the dinner table. Physical prompts may also be used to help children with eating difficulties, such as physically applying pressure to the chin or jaw to prompt chewing. This is a more intrusive strategy, and the parents of the child should be consulted before implementing it for consent and for generalization. Shaping also is used and involves differentially reinforcing successive approximations of the target behavior towards the terminal behavior. For example, to help a child eat a non-preferred food, such as carrots, The child may first be required to touch the carrot to his lips, then put it in his mouth and chew it, then swallow it. Some antecedent interventions that can promote appropriate eating are adding structure and predictability to the sessions. For example, having the child eat in the same room, in the same seat, with the same contingencies every session. The child's preferences can also be considered. For example, initially, you may want to present foods at preferred temperatures or textures. The child can also be given choice of non-preferred foods to consume, and visual supports can be used. For example, providing choice on a menu. And prompts can also be used along with positive reinforcement, such as providing a model who models eating the non-preferred food as well as receiving the consequence for eating the non-preferred food. The model can be a parent or a peer, and when the model is a sibling, it may be one way to involve the sibling in the interaction, especially when the parent implements the intervention in the home. Here's a sample program to teach a child with autism to eat non-preferred foods. The goal is clearly stated, which is Jake will consume non-preferred foods without engaging in challenging behavior across 3 days at 80% correct for 3 fruits, 3 vegetables, and 3 sources of protein. The teaching step categories are then listed. So for the sake of not including too much text on the slide, I've just included the categories here, but in an actual program, each step would be listed in a much more technological and detailed way. So the first step would be to conduct a preference assessment, followed by giving Jake choice of non-preferred foods in the form of a visual. An instruction would be delivered with the visual, outlining the target level of acceptance. For example, if he has to touch the food to his lips or his tongue, take a bite, or swallow it. And the visual should also show the consequence. So it may look like a first then board. So first, touch your tongue with the food, then get a Smartie. Shaping is used here, so the target level of acceptance will be systematically increased as Jake shows that he is successful. So after 3 trials of engaging in the target level of acceptance, the target level will then be increased until the food is completely accepted. Reinforcement will be provided, followed by data collection. So here's a sample data sheet that could be used to track Jake's performance during intervention sessions. For each food that is presented in a trial, a tally is made under correct or incorrect. A correct response involves accepting the non-preferred food at the target level of acceptance without challenging behavior. An incorrect response would involve not accepting the food at the target level of acceptance, or engaging in challenging behavior. At the end of the session, the percentage of correct responses is calculated by dividing the correct responses by the total number of trials presented. And that percentage is graphed for ongoing visual inspection and monitoring by the behavior analyst. Generalization and maintenance are important parts of programming for eating difficulties because of the impact on the child and on the family's quality of life. One way to program for generalization and maintenance is to train the parents to implement the teaching strategies with their child in the home. You also want to include multiple exemplars, including different types of foods, brands. You want to vary the presentation of the foods or drinks if this is an issue for your client, and program for a variety of food groups to ensure that the child is receiving nutrition across all the different food groups. You also want to thin the reinforcement to more natural schedules. Typically, we start with continuous schedules of reinforcement during the acquisition phase, but later we want to thin to intermittent and social reinforcers as much as possible. So going back to our sample program for Jake, programming for generalization for him might include parent training on implementing the program and programming for at least 3 different foods from each food group. Maintenance may also include thinning the schedule reinforcement systematically. So first starting with continuous reinforcement schedule, followed by an FR2, and then at least a VR2. So strategies based on behavior analytic principles are effective methods of intervention for eating difficulties in children with autism. These effective interventions include visual supports, giving choice, prompts, positive reinforcement, which is arguably the most important. And it's also important to program for generalization of target behaviors from treatment settings to the home, with parents, and to novel foods. In addition, maintenance of target behavior should be programmed for to ensure the child continues to engage in appropriate behavior over time. Lastly, it's important to advocate. Eating difficulties, it is very stressful for families and can impact the child's life in many ways, not only their health, but also their culture and the way they interact with other people. So I encourage you to advocate for evidence-based behavior analytic intervention for your children so that you can help them with their eating difficulties.